Hi, everyone. Thank you for joining us for today's webinar on understanding stimulant use and stimulant use disorder care. This series is hosted by UBC Health and the BCCSU and was developed to provide foundational knowledge on substance use topics with instructors and preceptors in mind. My name is Liz, and I'm the Partnership Manager with UBC Health and the BCCSU, and I'm joining you today from the unceded and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh Nations. A few housekeeping notes before we begin. This is a webinar, therefore participant videos are off and muted, and if you have any questions that come up throughout the presentation, please use the Q&A function, and we'll get to those at the end. We also have a short survey for folks to complete at the end of the session. Your feedback is very important to us. We read them all, and it really helps us plan our future sessions and continue to improve the series. So thank you in advance for taking a minute or two after the webinar to complete that. It's now my pleasure to introduce our wonderful panelists. I'm very excited to learn more about stimulant use and stimulant use disorder care from them, and I'm really looking forward to our conversation. And so first off, I'll introduce Andrea Stryline. She is a social worker with Providence Healthcare since 2015. And for the past 4 years, she has worked at St. Paul's Hospital within the John Rudy Clinic, the JRC, an HIV and primary care clinic that provides wraparound services for patients facing complex medical and psychosocial needs. Andrea has been enthusiastically running the Contingency Management Group, Rewarding Change, at the JRC to help support folks who are currently or recently using stimulants and are wishing to set goals and make changes in a low barrier and welcoming environment. Next, I'll introduce Dr. Kevin Nguyen. He is an addiction medicine fellow with the BCCSU. He is also a family physician who completed his family medicine residency training with the St. Paul's Hospital Family Practice Program. And prior to medicine, he also completed a pharmacy degree at UBC. And last but not least, Mark Haggerty. He is a peer navigator with AIDS Vancouver and runs the contingency management program at St. Paul's Hospital with Andrea Stryline. So thank you all so much for joining us today for this conversation. I'm going to kick off the discussion by throwing it to you, Kevin, to ask you to provide an overview on stimulants and stimulant use in BC.
Okay, so I'm going to start us off by talking a little bit about stimulant use and stimulant use disorder so that we all have some shared background information. So one of the main types of stimulants that many of you probably heard of already is cocaine. And on your screen here, you see the two main forms of cocaine. On the left side is cocaine hydrochloride. This type of cocaine is usually insufflated or it's dissolved in water and injected, or it can be snorted like powder cocaine. Of note, people don't usually smoke this type of cocaine because of low boiling point. And if you try to heat it up, it just burns away. Whereas conversely, if you look at your right side, you have cocaine-free base. This is the type of cocaine that's usually smoked, and people often refer to that as crack. You could also conceivably inject this. You'd have to dissolve it with something like vitamin C or an acid. You'll probably see around all of these like small orange packets, which is basically vitamin C in a pack, which folks can use to help dissolve their cocaine-free base to dissolve and inject. Okay, and then moving on to something called methamphetamines, which I'm sure a lot of you have heard of already. Three main types. On the left side, we have methamphetamine base, which is usually injected, or folks can consume that orally. And then the middle, very popular one, methamphetamine crystal, also known as crystal meth. This can be injected, it can be smoked, people can consume it orally, or it can be insufflated. And on the very right side, we have methamphetamine powder, which is either insufflated or consumed orally. Next slide. Okay, so some burden of disease when it comes to stimulant use disorder. I know a lot of our attention is paid to opioid use disorder and opioid crisis, but it's important to note that stimulant use has had a large burden of disease as well. So from January to June 2022, according to Health Canada, 47% of apparent opioid toxicity deaths involved a stimulant, and there were 5 hospitalizations per day from stimulant-related poisoning, which is a lot. And as per the Canadian Centre on Substance Use and Addiction, which is basically a group that analyzes the costs associated with certain diseases, they ascertained that the total cost associated with cocaine use was 4.16 billion Canadian in 2020, representing a 30% increase from 2014. And similarly, with other stimulant use such as methamphetamines, it was 3.06 billion Canadian in 2020, which was a 67% increase from 2014. They define total costs as healthcare costs, but also non-healthcare costs such as criminal justice costs and also costs related to lack of productivity from being unable to work and stuff like that. And very importantly, in terms of contamination, from 2019 to 2022, the rates of fentanyl contamination into the stimulant supply increased from 2% to 3.2%, which is really scary when you think about the overdose risk. Next slide, please. Okay, and I include this neat graphic for everyone to look at from the Canadian Centre on Substance Use and Addiction, basically indicating the healthcare costs from certain stimulant use. Healthcare costs, they're looking at basically physician time, ED costs, costs associated with other healthcare related things. You can actually see that the cost associated with cocaine has gone down from mid-2010s to now. But most importantly, I want to draw your attention to the green line, where since the mid-2010, mid-2000s, it's basically skyrocketed all the way up until now, indicating a lot of burden of disease. Next slide. And finally, to wrap up the burden of disease, this is from the BC Coroner's data, which looks at autopsies for folks and ascertains which drugs were related to their death. As you can see, fentanyl has gone up a lot, but our attention will be focused on methamphetamines, which in 2013 was 20% relevant to death, and is basically doubled to 43.3% last year, which is really scary to think about.
Thank you so much, Dr. Nguyen. I don't know if Andrea or Mark, you had anything you wanted to add to this. My next question was kind of shifting towards kind of more why do people use stimulants? So just pause.
Well, Liz, first of all, I apologize for not sending my bio, but I've also, for the last 6 years, I've worked at the Rapid Access Addiction Clinic at St. Paul's Hospital, which was open during for the opioid crisis back in 2016. So we get a lot of stimulant users in there, and I'm a former stimulant user myself. And at the time, there really wasn't a lot of support for stimulant users. So we started the contingency management or rewarding change group there 6 years ago. It was really successful. It's still successful. We stopped for a little while during the epidemic, and then we started up again with Andrea. But yeah, as a former stimulant user, like there really isn't anything medically I could do. Like there wasn't any treatment, so peer support was really important. And Andrea can talk about this too, but it's been very successful as well. And yeah, it's just nice to be on the other side of this. But also, most of the overdoses these days are like from smoking, and it's just because we don't know it's a tainted drug supply. We don't know what's in it. People had no intention to smoke fentanyl or anything else in it, but it's so tainted right now. And of course, I just want to add the other thing is like most of these, a lot of these overdoses aren't in the downtown east side. They're now spread in suburbia. People at home, normal people, whatever that means. But yeah, and we've had the last few months, we had 3 14-year-olds come in with opioid disorders that started from their stimulant use, and then they went on to opioids. But yeah, it's just a broad base, and it's really out of control. But again, the contingency management group has just been awesome.
Awesome. Thank you so much, Mark. And yeah, thank you for elaborating on your experience and background. That's great. And I know you touched on your contingency management group that you run with Andrea. We'll get more into that later. Definitely want to hear about your work there. You did touch upon kind of maybe some of the different types of populations that may use stimulants. So yeah, why don't we kind of dive deeper into that and maybe open up the discussion to around why might some people use stimulants, and are there special considerations that we should consider or clinicians should consider for different subpopulations that use stimulants?
I mean, an interesting just thing, like having worked at the GRC for the last 4 years, like the crystal meth use has just, like, it's been there, but it just seems to be like have exploded. So it's definitely there. And for special populations, I mean, it's diverse, right? It's not just one specific population. Like even in our group that Mark and I run, like half of the group, I would say, are cis women. There's definitely also like that PNP, the chemsex kind of group, and like that's a real phenomenon that we see.
Mm-hmm. I wonder if Joshua isn't here right now with us. He has more experience in running groups with the Health Initiative for Men around the party and play. You mentioned the PNP. Wondering if anyone here could comment on what that is and just give our participants a bit more of an understanding of what PNP is, if they don't already know.
So party and play is really quite popular among the gay community. A lot of young men are doing this. It simulates your sex drive, and it's usually crystal meth, and they can inject it or they smoke it or snort it. But it is very popular as like a party drug. But then we see the downfall of that later. So yeah, young men, I was young once and I remember being invincible, and it just takes a real toll on people. And yeah, Josh does a great job of promoting that at HIM, the Health Initiative for Men. But I see it at AIDS Vancouver as well. And we also have people in our group that we run that would fit into that category.
Great, thanks, Mark.
I think just another thing around sort of meth use is it's very inexpensive. The high lasts quite a while, like I think on average between 10 to 12 hours. So for a lot of folks that maybe don't have a lot of financial resources, it's a way to maintain a high for a long period of time. And it's I think that's also led to perhaps an increase in use compared to like cocaine, which is much more expensive. So like some of our folks, like, and, Mark, knows, like we have a couple, folks that use cocaine in our group, but a lot of them, I would say it's much more like around crystal meth use. Because a lot of our patients do, live in poverty, and not all of them, but some of them definitely do struggle. Homelessness and other things, yeah.
Mm-hmm. Yeah, thank you. And I've heard like instances where, perhaps if someone's experiencing homelessness, stimulants can help them stay awake. So it might be something where, there's maybe like fear of, they want to stay awake, and yeah, so many.
Yeah, that's certainly a phenomenon, like if folks are sleeping outside in tents or on the street, like, regularly people are having their backpacks, all of their, possessions stolen. And so a way to kind of cope with that is unfortunately, using stimulants, and then you're awake at night when maybe otherwise you'd wake up in the morning and everything, including your ID, would be stolen. Like it's just like a very regular phenomenon for sure. And even, for women, like it can be a safety thing too, where if you're sleeping outside, it might not be safe to be asleep. So staying awake can just be like a protective thing.
Also, I've talked to a couple of people, asked where the stimulant use started. It started in university. There's a lot of pressure there, I'm assuming. And so there might not be, there is stimulants out there that I'm sure the audience knows. some people that might be had that. But yeah, he started off. He didn't finish university, and yeah, just went into crystal meth, and life got really unmanageable really quickly.
Yeah, Mark, that's a really good point. Like there's, stimulant use, it's everyone, it affects everyone. It's not a specific, population for sure. Sorry, Andrea, I saw you went off mute.
Well, it's okay. But yeah, I mean, that definitely is a phenomenon. People think like, okay, I'm gonna, use my friend's Adderall or whatever it is, and, get through exams or, just through those tough periods. But then of course there's the consequences, right? Like there's so many ramifications from starting stimulant use. And I mean, we see it too, where, folks might start off just sort of on a recreational basis, maybe, on the weekend, once in a while, with chemsex or whatever, just, to party. And then over time, maybe it's every weekend, and then it's multiple times during the day, and then it impacts work. And, people are not necessarily showing up for work then, or the relationships are suffering, and like things start to just, fall apart. And so it can be really like a real struggle too. Like I really feel for folks, because it can just get out of hand very quickly, because it is so addictive. And it's one of those drugs where we sort of like, sometimes we joke a little bit, like, it's like, just don't experiment with crystal meth. Like, like there's a lot of drugs out there, but it's one of those really tough ones that I think it can be very challenging once it sort of takes hold. Yeah. But there's always hope, because that's part of what our group is about too, is trying to get people kind of back on track in like a positive and supportive way, because it can feel really overwhelming, I think, when people are in the throes of addiction. And
Yeah, for sure. On that kind of threads, can we talk about like the potential risks and harms associated with using stimulants, like health issues, also overdose symptoms, if, for the clinicians in the room?
Yeah, I can comment on that. So if you're using a stimulant, often it's from like illicit supply. So there's just harms with using illicit supply drugs or unregulated drugs. We talk about the contamination with fentanyl, or through benzos or other contaminants out there. So it could lead to unintentional overdose. Also how the process of consuming it, whether it be injection or smoking it, oftentimes if it's not, if the supply is from the street supply, it could be a risk of infection in terms of like injection into the injection site. Also with injection, you get blood clots into your like cardiovascular system. And there's also risk of STD/BI, so skin and tissue bloodborne infections, so things like HIV, HCV, Hep A, Hep B, including gonorrhea from using supply, the unregulated supply as well. If we're looking at specifically the stimulant, what can happen specifically from stimulants, as being a stimulant, in terms of side effects on the cardiovascular system, the blood pressure rises, the heart rate rises. Oftentimes folks get arrhythmias from that, tachycardia and arrhythmias. And from consistent use, you can get cardiomyopathies or other arrhythmias. And of course, likely folks have heard of using too much cocaine or crystal meth, resulting in like coronary artery vasospasm and myocardial infarction as a very serious side effect as well. And also to mention with stimulants, when I mentioned the 5 hospitalizations per day from stimulant use, oftentimes you can get something called stimulant-induced psychosis. So people use a lot of stimulants, become psychotic, they hallucinate, they have delusions, and they have to be admitted to the hospital, they have to be certified, they have to stay there for a little bit. Oftentimes that will wear off and they become less psychotic, but it can lead to chronic psychosis in the future. It can be really poor for someone's mental health if they already have underlying mental health conditions. Just in terms of like overdose on stimulants in general, there's this term called overamping, which basically means just use so much stimulants that it's overdose on stimulants. It wouldn't be anything like falling asleep or falling unconscious or anything like that. Just be very like delusional, psychotic, feeling too overstimulated that you can't really cope with that kind of situation.
Yeah, and just sort of speaking to that, stimulant-induced psychosis, like we see that at the JRC, tremendous, like even this week, like there's someone, who's one of our clients where, like they're hospitalized, and like this happens every week, like they're hospitalized with these things, and oftentimes they might lose their housing as a result because they're really not coping at home. Sometimes, there could be some, like, an aspect of violence. They might have completely trashed their unit, and then an eviction order, ensues. And so it can be very, very complicated, because the consequences, it's not just, even though it oftentimes there is, it'll resolve, within a couple of days. Like sometimes, folks will sit in the ER over a weekend and then it resolves and they get discharged, but then there might not be housing to go back to. Like it might be compromised as a result. And so it really can just have many, many consequences. Yeah.
Yeah.
And that's where the social workers get called.
So as this former stimulant user, like, I'm going to call myself an addict, although that's not the proper term, but I say addict just so I remind myself. But like the drugs are out of your system fairly quickly. But that's the thing about addiction. It's just like you're caught in that cycle, because you want to feel better. You want to feel better, and so you'll do a line or you'll do this just to feel better. But then that just sets off that chain, right? There was no drug addiction or alcoholism in my family. I was blessed, I guess. So it's not necessarily a trait. It could happen to anyone. But once you're in that cycle, it is so hard to break, and that's why the importance of the group is, like, just to know that I'm not alone, that other people are going through this as well, that I'm not crazy. But peer support is so important, but it's also like peer support in any work environment or any organization is important. Just to be able to talk to your peers and share what's going on with you. I'm going to talk about the group for a second, because the group has been amazing. The group is amazing because we have like 6-8 people a week. We used to have a larger group before COVID, but it's growing all the time. But just to be able to come to a place, because I never had that, and like 30. I mean, I was like drug addicted for 30 years almost, and I remember through my stimulant use, I contracted HIV, and that was 30 years ago. And so at that time, it was 93, and they said, don't make any long-term plans. And I was 29, and so like the death rate among people with HIV was quite high. And so I went on a binge, and I went on a 2-year binge. And then I remember in 1996, doctor said there's a new medication, these ARVs coming out, and it can prolong your life, which it has. Spoiler alert, I'm still here. But then, like, I realized, like, my HIV is not going to kill me. It's my drug addiction is going to kill me. And it was just so hard, right? There wasn't really I mean, there was NA and AA, but I really wasn't so much into that. But I mean, smart recovery too is important. It was a big part of my recovery as well. But yeah, just to be among fellow people going through the same difficulties, has been grateful. So the group itself we have 3 goals. We set 3 goals: a health goal, a leisure goal, and a health, leisure, and what's the other one? Thank you. So we set these 3 goals every week, and you get a gift card. First of all, you get a gift card if you first. We have gift cards that we give away. For your first time there, we give you a gift card. It can be a draw from $5 up to $100 gift card. If you come 3 times in a row, you get another gift card. But if you complete these goals, you'll get an additional gift card. So what the amazing thing was, and still is, we have people coming into the group, and it's just like, it's on their own honesty, and they said, I didn't complete the goal, and to me, that's amazing because they could have just lied and got the gift card, but they wanted that accountability to the group is really important. And it's just like, so I found that amazing, and I found it like, and the group is so supportive. It's okay. You didn't make your goal. We'll adjust it. But it's just been an amazing experience, and I wish I had it a long time ago.
And I think a nice aspect of our group is we do come at it from a harm reduction perspective. So there's a lot of groups where, like it's very much abstinence based, where it's like day one, if you've had a relapse, it feels like you're starting from square one. Our group, we're much more like, we've had people that have come in and said, I had a relapse this week, and they're feeling really bad. They might even be in tears, and we're like, hey, you're here, like, welcome back. Like, we're so happy to see you. And like, we just really create that environment where we're like, we accept you for who you are and where you're at. And like, let's set some goals. Like, let's try to keep this moving in a positive direction. And I like that it's always very concrete. So, our group runs every Thursday for 1 hour from 2 to 3 o'clock. Folks know like it's here for them. It's, it's JRC patients, but it's also all of urban health, the outpatient clinics at St. Paul's. So we did expand it so that we have folks from the RAC, the Rapid Access Addiction Clinic, can attend. They have to be screened in advance because we want to make sure that they're, group appropriate and, either currently using stimulants or recently, and that they're wanting to just set some goals and make changes. And so it's nice because we always try to really aim for very attainable goals using the SMART principles, specific, measurable, attainable, realistic, time bound. Because some people will come in and they'll just be like, okay, I'm not going to use any drugs this week. And we're like, okay, well, like, when was how much have you been using? And like, they've been using every day for the past 10 years, or, we're like, okay, well, let's maybe do something a little different. And Mark's really good with that too. With like sometimes for some folks, it might just be like, why don't you just like observe and like write down how much you're using this week? So even being able to like take that step back and just to sort of observe one's use, like some folks find that even like kind of helpful. And I think also like the aspect of introducing like a leisure goal, like something that people like to do for fun, because oftentimes, when you're really heavy in your addiction, your entire life becomes about procuring, using, and just sort of the hustle, of like trying, like, and all of your interactions become, around the substance. Like, and that's, I guess, in like an extreme case but sometimes that does happen. And so for a lot of our folks, it is nice for them to be like, yeah, like, what did I used to do? Like, some people were like, I used to love playing guitar. And so like their goal might even be to like, I'm gonna play my guitar for like 30 minutes one day this week. Or like just really simple things too, even like, I'm gonna go for a walk, like, and go to the park, like just really basic thing. Or like last week, I think we had people that were like working on their tans at the beach, and like that was like just like something where they're like, yeah, I'm gonna go to the beach. And so it's very like accessible, and we try to make it fun too. Like, we're pretty chill, right, Mark? Like, we try to make it like just like a nice environment, because we don't want it to be stuffy. We don't want it, like, we want people to feel like they can be themselves. Obviously, like sometimes we have to like corral people a little bit in terms of, we don't want it to turn into war stories or to get inappropriate. Sometimes people like there can be a little bit of that, like sort of like the P&P talk where like people start and we're like, no, like we have to get it back kind of into just focusing on the goals and things like that. So there's a little bit of some finessing that's, like, it's not easy running a group. It takes a bit of work, but I think we do our best. So and I think the ultimate goal is, we want to be a resource, for people when it feels like maybe there aren't that many resources. Like for opiate use, there's OAT, there's replacement, medications. There's really, there's like ADHD medication, but it doesn't really compare, so this is like an evidence-based approach, and it seems to have some some positive effects. So in terms of like reducing use, in terms of, you know, it is harm reduction. So we're not expecting people to completely stop using, but maybe it can add a sense of, you know, hey, I'm going to the gym now and I wasn't going to the gym. And like we have some people that they really need to stay busy. And so they're like, I'm gonna work. And so we have people that are like working a lot. I'm like, that's good because it like takes their attention, you know, like it provides something that they need to stay occupied as well. So that can be really helpful. But yeah, it's a bit of an adventure running the group. So
well, thank you so much.
Oh, sorry. One other thing I just wanted to mention, because we were really proud because, you know, checks come out once a month from the ministry. And we had our last check day, we had like 7 people show up, and typically nobody shows up on check day. Like it's one of the days where we're like, you know, like go grab a coffee or something. And we had our people show up and we're like, this is amazing. Like it's check day. So that just felt like a bit of a win. So
Totally. That's great. Testament to, you know, the community that you've built with your group. So thank you, Andrea and Mark, so much for sharing about your CM group at St. Paul's. You kind of nicely led me into a nice segue to Kevin on sharing a bit more about the different evidence-based treatment options for stimulant use disorder. And then we can kind of dig deeper into the CM group, because I do want to hear a little bit more from you too.
Okay, so to review some of the treatment options for stimulant use disorder, as an overview of pharmacotherapy, the evidence for stimulant use disorder in terms of medication is limited and inconclusive. No approved medications. So our gold standard and standard of care currently is currently non-pharmacotherapy approaches. Next slide, please. Okay, so just quickly over the pharmacotherapy, there have been multiple meta-analyses that have found no evidence for efficacy for any forms of pharmacotherapy. We've tested quite a number of things: SSRIs like sertraline, allopurinol, gabapentin, oral naltrexone, bupropion. However, some studies have highlighted that psychostimulants as possibly having an effect, but definitely require further study. And there's one specific study that showed injectable naltrexone, also known as Vivitrol, in combination specifically with extended release bupropion as having some effect. Of note, injectable naltrexone is not available in Canada right now. And another study showed mirtazapine as having some effect specifically for the men who have sex with men population in the party and play context. Next slide, please. Okay, so a little bit more on psychostimulants. Some promising results so far based on these kind of low quality studies, specifically for dextroamphetamine and methylphenidate. However, it's important to note that these studies are relatively low in quality, many methodological limitations. So definitely there is insufficient data to fully support clinical use. Some promise so far, but we really need higher quality primary studies to start using psychostimulants regularly for stimulant use disorder. Next slide, please. Okay, so most of our talk today, as some of you already heard, is regarding non-pharmacotherapy, specifically contingency management. So I'm going to review some of these approaches, including contingency management a little bit, go over them and review some evidence regarding those as well. Next slide. Okay, so we've already alluded to contingency management a bit so far, but basically in a nutshell, it is a type of behavioral therapy where individuals are rewarded or reinforced for certain positive or desired behaviors. In the context of stimulant use disorder, it can be abstinence from stimulants, but also, as Andrea and Mark have mentioned, certain behaviors as well linked to that as well. And generally, the positive reinforcement is some type of gift card or a voucher or a chance to win a prize. It really depends on the specific program that the person is enrolled with. Next slide, please. Okay, so contingency management is supported by a large body of evidence. There was this large 2018 systematic review and network meta-analysis looking at psychosocial interventions for cocaine and amphetamines. This included 50 RCTs. I included a snapshot of the forest plot here. I won't talk about it too much. Basically, if you look at the top blue bullet point with the confidence interval surrounding it, it's looking at abstinence at 12 weeks of the treatment program, whatever that might be. And then below that, the green line is abstinence at the end of whatever the treatment program it is. And then that middle teal bullet is abstinence at longest follow-up. So after the program is ended, however long it might be, follow-up after to see if the effects are sustained post-intervention. And also there's dropout rates at the bottom as well. So basically, as you can see here, contingency management had a significant effect at 12 weeks of the program and at the end of the program, but it doesn't seem that the effects of contingency management will last after the actual program ends, however long after that is. Next slide, please. Okay, and there's a lot of attention paid to contingency management combining with other types of psychosocial treatment. In summary, it only seems that contingency management combined with something called the community reinforcement approach, which I'm going to discuss later, has significant effect. And of note, it actually seems that that specific combination has long-lasting effects even after the interventions are completed. As you can see, combined with other things didn't seem to have much effect. Next slide. Okay, so just in summary, according to this systematic review and network meta-analysis, contingency management plus community reinforcement approach versus treatment as usual, which I forgot to mention is basically any non-structured or non-manualized approaches. So things like case management, things like that. In summary, contingency management plus community reinforcement approach was the most effective intervention for stimulant use disorder, and also very acceptable as an intervention. Next slide. Okay, just quickly onto cognitive behavioral therapy. This is often used for stimulant use disorder and substance use disorders. And I'm sure a lot of folks have heard of CBT before, but basically it is psychotherapy aimed at helping someone identify their thoughts, feelings, and actions that occurred before and after stimulant use. And the goal is to uncouple drug use from certain habits, behaviors, and emotions, and use learned coping skills instead. Next slide. So basically, CBT, does it work? Hard to tell. Right now, probably not, specifically for stimulant use disorder, at least by itself. Some studies have looked at it, lots of mixed outcomes, but it's hard to determine its effect based on the studies being small in size and poor quality data. Next slide. And this is a snapshot from the 2018 Systematic Review of Network Meta-Analysis that I mentioned already. As you can see, the bullet point and the confidence interval across the middle line, so it doesn't seem to be more effective than treatment as usual for abstinence at 12 weeks, abstinence at the end, and certainly in the long follow-up too. Next slide. Okay, so I mentioned this community reinforcement approach. Community reinforcement approach, CRA, operates under this idea or belief that someone's substance use is strongly tied to the external factors, whether it be their relationship, if they're in a relationship, their friend group, or their job. So community reinforcement approach is highly individualized, looking at someone's external factors related to substance use and trying to address those factors in hopes to ameliorate those as triggers for their substance use. So for example, if someone's substance use or stimulant use is strongly tied to a difficult relationship, whether it be marriage or what have you, then offering someone marital therapy or some type of therapy to help their relationship to help address that as a trigger for their substance use. Next slide, thanks. So CRA not really evaluating systematic reviews by itself. Most of the research has looked at it in combination with contingency management. Next slide. The studies that have looked at CRA by itself, as you can see, there's not actually that many studies, but it looks like it doesn't have effect by itself at 12 weeks and an intervention. However, it did have some effect, show some effect, at least in the longest follow-up after intervention has ended. And that makes sense as it gives people skills and addresses their triggers that they can carry on forward after whatever intervention has ended. Next slide. Okay, so quickly onto something called a matrix model. You can think of the matrix model as basically a combination of many specific strategies, 12 steps, CBT, family education, counseling, motivational interviewing, and using all those approaches, combining them to help someone with their substance use. Next slide. Thank you. And some of the studies, not many studies on the matrix model, but the studies that have looked at it have shown that it does seem to be effective for folks for stimulant use disorder. But of note, it seems that the superiority is not sustained at the end of treatment and not sustained at the follow-up after treatment as well, which is a recurring theme for a lot of our interventions for folks for stimulant use disorder. Next slide. Okay, and to wrap things up, bed-based treatment, which is basically going to like a live-in facility, also known as a treatment center. There are plenty around, like Pacifica and other private ones. You basically live in a facility for usually a number of months. Usually it's 3 months. It can be shorter, it can be longer as well. Very structured, it's very regimented. And of note, when folks go there, they get a lot of psychosocial treatments, such as probably contingency management, group therapy, individual therapy, CBT, DBT, lots of supports in those type of facilities. Next slide. Research for bed-based treatment for stimulant use disorder specifically is quite scarce. And actually, there was a systematic review that looked at it for various substance use disorder, including stimulant use disorder. They actually indicated it was also kind of mixed, suggesting improvement or no difference. However, there are many methodological weaknesses in study designs, and overall, it's just really hard to study a treatment center based on all the interventions that you would get for specific substance use disorders. Next slide. Oh, the references. Just wrap up the bed-based treatment. If you're considering a bed-based treatment for someone with stimulant use disorder, right now the evidence is mixed for it. But if you have someone who has unstable living situation, or they've been in a treatment center before for another substance use disorder and they found it effective, then it would definitely be a good idea to consider that for someone if they're so inclined.
Thank you for that whirlwind overview of the different evidence-based options. So yeah, kind of bringing it back to the contingency management program and the effectiveness of that. And, with Mark and Andrea here, would love to kind of delve a little bit deeper into that and your experiences in running it. And, like a question I have is, how does someone join your program? Like, is it referral based, or you mentioned there's screening, and maybe if you could share a little bit more about like what it's like to be part of that program.
So we get our referrals from within. I mean, obviously the patients of the John Rudy Clinic, they kind of have direct access. They have to talk to me or whatever social worker is running the program at the time, to just do, and it's a very informal screening. Essentially, do you use stimulants, or recently have used stimulants? Are you wanting to make changes? And then, we kind of get a sense as well if they're group appropriate, because we have some folks where they might be very disruptive or inappropriate. And so in that case, that they might maybe be more appropriate for like a one-to-one type contingency management model, but not necessarily a group. We also get referrals directly through the RAC. And so we have the social workers there that usually will email me, and they've screened, patients that are accessing the Rapid Access Addiction Clinic at St. Paul's Hospital. And then, I would say, like, what do you think, Mark? Maybe half of our group is from the RAC, maybe?
Yeah, about half.
Yeah. And then I guess on occasion there might be, like an inpatient unit on like Urban Health 8A, there might be someone that's admitted up there that like will come down for group. But they just have to get screened basically through social work. And it is fairly informal. Like, it's not like a lengthy process. We just want to make sure that they're in the right group. So, I like inherited this group from the previous social worker. I wasn't an expert in stimulant use or running this group, but it's just one of those things where, you just do it every week, and then you just get to know the patients and, and kind of where they're coming from. And in general, they attend for 12 weeks. I know some programs are 16, up to 16 weeks. They can continue to attend after that, but they don't necessarily get to draw for gift cards after that period, just because I think just funding, right? It's and I don't know what would else, I'm not sure what else would be helpful to know about the group in terms of how it's organized. Or
Well, I'd like to a couple of things on Kevin's slides there. That one is, like, if you're trying to get to Pacifica, good luck. The wait length in there is like 3 months, 4 months to get in, and the other places you can go is recovery houses, and there's some good recovery houses, and then there's some crap recovery houses. But the number one thing is, like, I use drugs to make me feel better. And whatever trauma I had in my past, I would just stuff that down and it was great. All of a sudden, you're not using drugs anymore. All that shit's coming up. And if you don't have a counselor or someone to see, and again, like Three Bridges has counseling, try and get in there, right? So if you have low income, you're not going to get a counselor right away. And like, so it's kind of a mixed bag here. But I feel like the counseling part is very important, and it's like lags in the system. Because I mean, all of a sudden, okay, it's like you have a chaotic life, right? And it's like all of a sudden it's up and down, and it's like chaos becomes normal. And all of a sudden you've taken your drugs away, and now what? It's just like we get bored, or we don't know what to do with ourselves, right? That's why the group is great, because we make goals in that. But yeah, the group ends. Now what? So there should be more available. I mean, Three Bridges has them as well. But yeah, you need some things to go in order here. And, again, counseling is like, if I, didn't have a counselor, I'd be using. So just to expect people to stop using, when you go to the group and not have any aftercare, which is really important, but not available to all people. So that is an issue. I mean, St. Paul's is coming up with the Road to Recovery. We're gonna have 14 in detox beds in the hospital in September, and then we're gonna have 50 outpatient treatment beds later. But yeah, it's a continuous problem with people, and yeah, just if we could all work together, it'd be great. And if the system wasn't broken, that'd be awesome.
And I think that also speaks to like the social determinants of health. Like so much of, our health is based on all these factors, housing and income and like all of these things that we sometimes take for granted when we have in place. And so I think it is important to remember that, and to have, I think our patients are lucky. Like we have 4 social workers at the John Rudy Clinic. Like we provide wraparound services, to our patients. I wish that model existed everywhere. For folks struggling, because we do like everything from housing applications to income assistance advocacy. When there are evictions, that like we sometimes we're successful in like fighting those evictions, and like because if you lose your housing, like what else happens? There's like oftentimes your drug use increases. Like there's just all these effects that take hold. So yeah, all those like psychosocial, I think, supports are really, really important. And that counseling piece, like Mark was saying, like it's huge. And just having that emotional support, being able to process. There's a lot of folks who have, a lot of trauma in their histories. And that can really come up as well. And just learning different coping, mechanisms for how to deal with difficult feelings. Because ultimately it is, hard to feel certain ways, right? And so a lot of times, we run away from feeling sad, from feeling scared, from feeling a lot of things. And, so it's like learning how to manage really difficult, big feelings. And if you don't have someone to do that in a safe way, then it becomes, really challenging. So in some ways, it's not necessarily surprising that there's like a drop off. Someone goes to treatment, they have all this support, all of this time to really, focus on things, and then it maybe drops off afterwards. So, if I had a wish, it would be that there was some way to like keep these things going, or when people get out of treatment and there's no housing to go to, it's like, well, what happens, or the only housing that's available is a private SRO or somewhere that really isn't safe and where there's rampant drug use, then that's probably going to affect whether or not you start using again as well. So, and that comes back to just BC's housing crisis. Like it's epic proportions in terms of just the cost and lack of supportive and appropriate housing. And these things are so complicated. Like sometimes it can feel so difficult, right? There's no one answer, but there's lots of baby steps that we try to take, and we do our little bit.
So one of the questions that somebody asked was like, how was I treated by by healthcare professionals when I was in my addiction? The answer is not well. If I went to the emergency department and needed help, it was just like, it's just another drug addict seeking drugs, or, it's like, we had so many people who won't go to hospitals because of the way they're treated. And so, I mean, that's starting to change. St. Paul's is really good that way. But yeah, like, you're just a drug addict, right? That's the first thing they see. And so that's what, when St. Paul's opened the clinic, the rapid access addiction clinic, and so it's been really supportive. But yeah, it stopped a lot of people from seeking medical help, just the way they were stigmatized and judged.
Yeah. Thanks for bringing that up, Mark. I'm wondering at the second part of their question, was there anything that any healthcare professionals did that was helpful? And they were saying things that they would say or do when you were actually initially not thinking about change. That was helpful.
I mean, one thing is, again, this not so much with my addiction, but like with my HIV. 30 years ago, when I got diagnosed, I thought life was over. I was dirty. I was like, it was just like the stigma around HIV was horrible that time, right? Like, it was AIDS. You had AIDS, and I just remember a nurse, because I felt so bad inside. I just felt horrible and worthless. And I remember I was in the hospital, I had pneumonia, and I just found out I had diagnosed. And I remember a nurse. I always tell the story, but like, she actually put her hand on my arm, which was like, really, because I have AIDS, right? But she said, "You're going to be okay." And it's just like that kindness, and just like, I trusted her. I don't know why, but I did. But she touched me, which was a huge thing, and just talked to me like a human being. And you're going to be okay. So these things that people do, like in healthcare, like, you don't know, like, you plant some seeds, but that meant so much to me, that she wasn't scared of me, and just treated me like a human being. So that was amazing. And I see, and with our own clinic, like, people coming in, they're respected, treated like human beings, and they're listened to. And so the clinic's been great. And same thing up at JRC too.
Yeah, thanks, Mark. It's so powerful. I think we have time for maybe 2 more questions. I see someone asked, do you know what types of supports are available in the Okanagan, and is your program available virtually?
I don't know about the Okanagan. Maybe I will look into that and let you know, Liz.
Yeah, sounds good.
I like the virtual idea, though. That's something we should look at.
So currently yours is all in person at St. Paul's? Yeah. And someone from Jason, they run a virtual CM group on the island, and a struggle has been going from the number of referrals to those who actually attend the first group. Do you have any similar problems or solutions you've come across to help with this?
It does take time to build up your group. Like, there were, multiple weeks when we first got started, sort of after the COVID restrictions, where we would have 1 or 2 participants, and we were like, hey, that's a win, right? And that's fine. And then I think just over time, it just sort of builds up. Sometimes offering food helps, like that can be a big draw for people. I don't know. What do you think, Mark? Like, what?
Well, I can understand people signing up right away and maybe not attending. It's just like, because they're on stimulants and they might have the best laid plans, but don't give up, because they will come. And like, yeah, they will come. And then the word of mouth gets out there. And we have some people bringing other people in before they're screened. And so we work on that. But yeah, I mean, it's awesome that you have that. We just started a virtual clinic for the RAC. For the addiction part, and that took a while to take off, and it was focused on the Sunshine Coast, and now we're in North Shore. But yeah, so patience, that's all I can say.
Yeah, I think that's a great kind of place to end it, with don't give up. That's, yeah, really, really great. And just quickly seeing someone in the Q&A saying their organization actually pays attendees minimum wage to attend the group. So definitely funding can help as well. So yeah, just to wrap this up, thank you so much to the three of you for sharing your expertise, your experiences, and your time. And thank you to everyone for joining today. I do want to note that this webinar series is going to resume in the fall, so please stay tuned. If you want to keep up to date on those, you can sign up for our monthly newsletter that just got popped into the chat. And also a reminder to please fill out our post-webinar survey. The BCCSU does have a practice update on stimulant use disorder, so we can share that in the post-webinar email out, or folks can look that up online. But yeah, thank you again for joining us, and thank you, Andrea, Mark, and Kevin, for this conversation.